Right. Well, good evening, ladies and gentlemen. Welcome to this YPS Zoom lecture. Uh, I, I introduce Dr. Mark Nicholson, who's a reader in system safety at the Department of Computing at the University of York.
And what I'm going to talk about today is the introduction of new healthcare technology, in particular AI. And as a person particularly interested in the safety of technology, what we need to think about, what we need to look at with respect to that introduction to make sure we do it safely. So, um, healthcare technology, healthcare itself is going through a really quite a large change at the moment. It's very rapid. There's all sorts of drivers for that. If you look at the new NHS 10-year plan, that actually asks for three shifts in capability. It's looking at moving from hospitals to communities. It's looking at going from treating sickness to doing prevention. But the one we're particularly interested in today is that transition from technology that is analog to more digital. And in particular, the move from software-based systems into AI-based technologies. Now, the exponents for this have been putting forward new and wonderful things that they think will get in terms of gains from this over the last 5 or 6 years. There's been a very rapid increase in capability. So the exponents talk about how we'll change all of the different parts of healthcare, from the clinical practice to the patient journey, through how we actually understand diseases and assess those diseases. We'll be able to make that much more technological. That will give us great gains in terms of throughput and in terms of the quality of the health of people over their lifetime. They've decided that it will help throughout all the different levels of information we need in the healthcare processes, right down at the sort of DNA molecular level, through cells, through individuals, and of course through populations. And if we can get that right, of course, that will allow us to do prevention better than sickness. They even have an approach to doing that. They're talking about a four-stage process. For one first part of AI, we've sort of got through phase one now of using what we call machine learned components, and that's now starting to come in. And we're now starting to think about how to use things like chatbots in this area. And I'll talk about that. So we go from a foundation building, that's over the last 10 years, pilot implementations, scaling it up, and then it becomes a standard part of practice. And I guess we're sort of sitting in level 1 and 2 at the moment, with the start of that scale up. And, they envisage a really high change in that AI technology over the next 10 years. So let me just give you a couple of examples of the sorts of things we're talking about using AI for. So the first generation was to take all that data that we've got from past healthcare activities in the NHS, things like our breast screening processes and programs. And from that, we can actually start building AI models that will help us as part of that pathway. So we can take scans and then we can get the AI to look at those scans and diagnose cancers or no cancers or the potential for cancers over the next few years. So we take the results, run them through the machine, and the machine then gives us some insights into the health of that patient and the future health of that patient, so we can then decide what we're going to do. And there's lots of work in that area. Every week you'll find a new application that's starting to look at that. And AI is pretty good at that sort of stuff. And that's what we call machine learning. Well, of course, we're moving on into the wonderful world of chatbots. Why is this useful to us? Well, the NHS spends a lot of money on people that do not show up for consultations, for they cancel at very short notice. They reckoned in 2021 that 7.6% of outpatient appointments ended in the did not show. So there's lots of work going on at the moment to try and reduce that because we get extra capacity. How do we reduce that? Well, we get AI to look at the data for why people did not attend, why people cancelled at short notice, so that we can then predict when we're setting up an appointment whether people are going to are likely to not show or to cancel, and we can try and intervene to reduce that. And people have got approaches where that will then allow them to start sending people safe messages, do phone calls. It might be that that phone call is from a chatbot rather than a real person. There's also some work going on at the moment around how we can improve the transport to hospitals, because actually quite a lot of them are due to that sort of reasoning, and AI has shown that up quite clearly. There are a number of pilot schemes around the country. Over here in the east of the country, one pilot scheme reckoned it had managed in the first year to reduce do not shows by about 30% as a result of employing this sort of technology and this sort of approach. So you can see how people are trying to say that there's a significant gain here, both in terms of the medical interventions we can take, what we call the healthcare pathways, but also just the sheer throughput and of the NHS, making it better at keeping information, at using information to make sure that we get a very efficient flow through our hospitals and other healthcare situations. Now, that's great. And I'm not saying there isn't a really good potential gain from this, but, I'm a system safety person. I'm interested in those occasions where we may have negative outcomes, and trying to make sure that we understand that potential, make sure that we don't have it. So the question that I've always got when I'm looking at technology and new technology and introduction of capability is, well, is it safe? Now, to motivate how we answer that question, I'd like to take us back about 40 years. And about 30, 40 years ago, we had the last big revolution in technology in many domains, including the health domain. And that was the introduction and use of software in systems. So coded software to control machines, to provide information and all that sort of good stuff. And that technology brings in potential risks, potential harms that could happen. And here's one of the early real cases that led to a lot of work, particularly at York in the 1990s. So there's a machine called Theric 25, and what Theric 25 did was it gave you radiation therapy to cancer patients. A new version of this machine came out in the early 1980s, and we can show that at least 6 patients, and probably more, ended up with the radiation doses over 100 times greater than normal. So we're pretty sure that resulted in death. It definitely resulted in serious injuries, including radiation burns and poisoning. So why did that happen? Well, when you start looking into it, you find that there was poor software design, poor development processes, poor analysis and verification of the capabilities of that software to contribute to the patient getting good radiation doses. We found that the operator did not understand what the machine was doing, what levels it was at. They didn't notice what the problem was. So I think as we go forward, we'll want to think about both of those courses, approaches. Are we making sure that our new AI, our design and development, that is good? Are we making sure that the human in the loop can interact with those well? As a result of this introduction of software and complex systems and the potential for them to do harm, a whole new discipline got created. It's known as system safety engineering. It's been around for 30 or 40 years now. It's really quite mature. And essentially, it is trying to prevent accidents caused by engineered artifacts. And if it can't stop them happening, it wants to minimize the consequences of that, particularly even those things that are the unknowns in here. That's quite exciting. So the emphasis of system safety is around risk, and I'll tell you what risk is. It's a measure of safety. For new systems, we try and build in that safety. We try and put mitigations in. We try and make sure that we understand how it could go wrong and make sure that can't happen. We also want to do effective management of that safety and the safety risk when it's in service. And we make sure we look at the whole healthcare pathway, the whole capability that piece of technology sits in, to try and look at the contributions rather than just one individual bit. And I've just listed here all the different sorts of contributors we take into account. And we try and predict what could go wrong and deal with it rather than retrospectively looking after the fact. Now, that approach, that discipline, has been used in many different domains. For instance, it's used extensively in the automotive domain to make sure all the computers in your vehicle and all the capability, things like your active cruise control, actually work well and don't cause harm to you if and when they go wrong. We also use it in the aircraft domain. And here, once again, it's been used for about 30 years. It's proved to be highly effective. If you look here, I'm showing here a graph of the number of accidents per million departures that we're getting per year, despite the huge increase in the use of air travel. The number of accidents is being going down, the safety risk associated with that. So your chance of an accident happening every time you fly or for every hour that you fly, it has come down quite dramatically and is running along at a very slow level. And system safety engineering is the heart of making that happen. Of course, it doesn't guarantee I'm not going to have a crash. It doesn't guarantee that we're not going to have issues. I could point you to Air India. I could point you to the McDonnell Douglas crash yesterday in America. But we're forever looking and thinking and using this approach to engineering to try and drag the chances of those bad events happening down to an appropriate level and managing that. That's great. But what about healthcare? Well, yes, we use system safety engineering currently in healthcare for the technology we employ there. It's known as clinical safety management. And here there are standards like these DCBs that's been around since 2011 and 12 that ask developers and operators of technology in healthcare to think about the hazards, think about the risk, evaluate the level of risk they've got, put in risk controls, manage against those risk controls, and make sure that therefore their healthcare has risk of harm at a low and acceptable level. So we've been doing that for quite a few years. It's embedded in the system. We look quite extensively at the contribution to that safe healthcare, and we look at the two types of technology, things like the electronic health records, which obviously use software. Now, a failure in the electronic health records can't actually directly cause you harm, but of course, what it does is give incorrect or missing information potentially to clinicians who then make an incorrect decision. They maybe give you an antibiotic that you're allergic to, and then that can cause harm to you. So we still need to think about that because of the decision making based on the information it provides to us. We also have something that's more direct. Software is used in pacemakers. We're starting to do robotic surgeries. And there's a lot of stuff going on at the moment for diabetes and how we can manage that and use software technology-based systems to give you the right doses of insulin, for instance. Now that software is used directly either to diagnose or to treat people, and therefore that has the potential to directly lead to patient harm. So in this case of the Therac, it actually set the dosage level too high without the operator knowing that it had been set at that level due to some issues with how it set those levels, and then that directly caused harm to multiple patients. Once again, over the years, we've got lots of experience of doing this, and we have a number of principles we use to check out any piece of software to make sure that it has good qualities with respect to safety. And we call those the 4+1 principles. And those are actually generated at York and are embedded across many domains now. So we do look at, and we do have an approach to doing, and it's quite mature for how we look at software and potential harm of software and how to minimize the risk of that software. Of course, we're moving on from that hand-coded human produced software into the use of artificial intelligence. And so we're currently having to revisit those questions around safety and ethics in those healthcare pathways. It's not enough to just say we've got a level of safety. We have to ask ourselves, is it ethical to do this as well? And that might be a slightly different bar to get through. And I'll talk about that as well. Where are we? We have technology already. It does good things for information. It does good things for in medical devices to directly help patients. We have approaches in place using something called system safety engineering to address those. And we're now starting to move towards putting AI in. And we have to ask ourselves, how do we make AI safe? And what does even a safe AI mean? And there's been quite a lot of work trying to think about how that can happen, particularly at York and other places. To make this good, we have to address quite a number of different issues. So I'm just pulling out a number of them. The first one is we are using artificial intelligence to take a load of data and then turn that data into a model that does something useful for us. So, for instance, we might want it to help us diagnose whether a patient's got COVID or not. So what we want to be able to do is put in patient data, and it gives you information around whether that patient has got COVID, given their past histories, how poorly they're likely to get, what sort of interventions you'd want to put into place. And not surprisingly, when COVID hit us, many researchers had lots of time available to them, so they produced predictive models, predictive tools, trying to understand exactly that. Have we got a COVID patient? How bad is COVID going to be for them? What interventions should I put into place? After COVID, lots of reviews were taking about the capabilities of those tools. So there's ones here I've referenced from America, from MIT, the British Medical Journal, Nature, and you can see hundreds and hundreds of these models and potential tools were looked at. The consensus is pretty well none of them were any use in a clinical setting. As a result, there's a few of them, and if we'd actually ended up using them, would have been harmful. And luckily, our processors spotted that, and even under stress, stopped it happening. At the time of these reviews, the authors typically said that they could see why that was a problem and that they could improve things in the future. 5 years later, that capability has increased quite dramatically. There are things now that we can do that we couldn't do at that point. But we still have to make sure that we don't just throw a lot of data, build a model and assume it's all okay. We want to look at whether that's a good model to use to help us in a clinical setting. The second one is we start using these sorts of interactive technologies like chatbots, we have the problem of them going a bit rogue on us. Now, we're not in Terminator territory here, but here I've talked about one that I sort of talk about gaslighting. So here was a chatbot that a user was interacting with. They were trying to work out whether a particular film, an Avatar film, was available at their local cinema. The chatbot got confused about the date and was saying information that was incorrect. The user tried to correct them. The chatbot then, as I've put in red here, refused to accept that. So it said, no, you're wrong. The date isn't 2023, it's 2022. When the user insisted, the chatbot then says, you're wrong, you're confused, you're rude. It then, when it started to accuse them of trying to annoy the chatbot, which is quite interesting since it's a machine, it then started to humiliate them, saying that they ought to apologize, they were wrong, their behavior was inappropriate, etc. Now, in this case, you just turn it off and walk away. Because, if I don't know where Avatar's on, I can always go and find some other means. But you think, if I'm using this chatbot as part of a medical procedure, as part of a triaging for medical care, as part of mental health activities and interactions, what's going to happen when you use this technology for those vulnerable patients? And because I'm not saying it will happen, we've got to make sure that it doesn't happen. We've got to keep the chances of that happen down to a low level and make sure we've got the right things in place to deal with it. And of course, we have that final one that everybody's sort of worried about under Terminator, which is the killer robots. Now, deliberate attempts to kill you by a robot is one thing into the sci-fi realm. Inadvertent harm by robot has already happened. There's one or two occasions in the medical, but in particular here, the example is where a maintainer was inspecting a robot on a production line, and the robot mistook them for a box of food, attempted to put them onto a production line, and unfortunately that led to significant injury, and they later died in hospital. So if we're going to start using robotics, we have to think about the harm that they can do. And for instance, we are thinking about using robotics in physical therapy after strokes and things like that. And the potential to harm those patients is there. And we have to do analysis and make sure that we've got that under control. What we're really trying to do here is make sure that we have an absence of unacceptable risk of harm caused by the use of that artificial intelligence in a healthcare pathway. And this diagram here shows how that might happen. So we have a circumstance where the AI fails, That leads to the software that's embedded with fails, which means that the service that you're providing fails. That leads to potential hazardous situation, a harmful situation. And at the end of it, we have the potential to harm that human being that I've got at the end, who's there to be helped as part of that health activity. Now, we ought that propagation. We want to be able to try and identify how that could happen, so that we can understand and address it. And in fact, we typically, historically, for technology, things like pieces of software, like systems within our healthcare, we've relied upon the human being, the clinician in this loop, to spot there's been a failure, and they're the ones that are stopping bad things from happening out at the at this level, so that it doesn't cause harm to people. But there's an issue here, isn't there? One of the things we're doing to improve capability is we're starting to alter the work of that human being. At the moment, we're in a situation where we've got a human in the loop. The clinician looks at the information provided, they work out what is going on, they undertake the information and decision-making activity. We have lots of people talking about how to move that on so that the AI works out what to do, and all the clinician is doing is just confirming and checking that. It's called human on the loop. And finally, of course, we can take the human completely out of that loop. We can remove them. And here we can talk about how the AI works out what to do, works out what's happening, works out what to do, executes it without any intervention from a human. If you notice, we've got humans here as optional. Now, obviously, that is a situation which is significantly different to what we do at the moment, and has potential to cause harm. So as we move through this sequence, we can get an improvement in speed and accuracy and throughput. But at the same time, we're removing the human involvement, reducing their capability to spot things and deal with the issues within that process to make sure it doesn't cause safety harm. What we're trying to do here is understand the level of risk that we have from a safety point of view. And what we want to do is try and mitigate that. So we want to put barriers in. Here's these lines. These lines are our barriers, our mitigations. If we understand how an AI could fail and how that could propagate to harm to a person, we can actually put in mitigators, what we call guardrails, to stop it. And our first line of defense is what we call extrinsic guards. And what we're basically doing there is saying, we'll put in a guard that even if the AI fails, that won't be a problem. We'll work it out and know that there's been a failure, so we can do something about it. We can let the clinician take back over maybe and do something about it. We can also provide what we call intrinsic guards. So those things inside the AI that make sure that the AI itself is built properly and doesn't put incorrect output out. So we can have a look at that as well and try and reduce our safety problems, our safety risks that way. And there's been a huge amount of work on this, and we're starting to build these guardrails to understand what to do. So, for instance, if you've got one of these chatbots that's talking to people to do triaging, and you start getting words from the person who's talking to that chatbot, like suicide or self-harm or other such things, you can put in a safeguard that pulls the conversation away from the chatbot and gives it to a human being. That, of course, reduces the risk of the harm that the chatbot can cause a problem and allows an intervention as appropriate. We can get the human to take over and make decisions. We can get the human to be that on-the-loop checker as well. Now, with the pace of AI change, there are some new things on the block that we just don't know how to put good guardrails in for at the moment. Obviously, we wouldn't let them out into the real world yet, and there's a lot of research we're doing to try and overcome that problem as we speak. So we can mitigate the risk, and governments are starting to realise this. This is the voluntary guardrails from the Australian government, asking anybody who's introducing AI to work to. And in fact, interestingly, if you want government money, like government health money, then the voluntaries go away and it becomes mandatory. You have to put them into place. You have to include risk management processes that we've just been talking about. You have to look at the data and the quality of the AI and all those sorts of things. So we're starting to see how people are trying to make sure that mitigation is in place and works well. Now, what you can do there is you can say, well, I've put in AI, that AI has capability, brilliant. It has the potential to go wrong. We've minimized the chances of that happening, and the risk for safety is at a given level, what we call residual risk. But that's not enough. We have to ask ourselves, is it ethical to put this into place? And so we have to widen it out, not just from a safety perspective, but also to think about the ethics of it. And we've had a number of researchers from philosophy and various other places looking at this. And we've come to realize that there's three bits to this. We have to work out who is going to benefit from the introduction of this AI. Hopefully mostly the patient, but it might be the clinician from reduced workload or more efficient workload or better information. Who's going to take the risks? Who could be harmed by the introduction of the technology? And that might not be the same people as make the benefits. But also, for the first time, we are taking away autonomy from human beings to make decisions. We're moving it from the person, the clinician, to the technology in a way we've never done before. And we have to think about, is it ethical to do that? Is it appropriate to do that? And we have to do that as a balancing act across all the stakeholders in our system. And if you look at things like the principles that the World Health Organization has put together, they're talking about those sorts of things as well. So this is their list from 2023 around human autonomy to make decisions, around the safety, about how to understand what the AI is doing, and all those things that we've been talking about so far. And we've identified a three-step process for doing that. You work out what the benefits are and who's going to get them, what the risks are and who's going to be at risk of harm, the impact of human autonomy, turn that into a risk rating and get appropriate approval. And the more ethically risky it is, the higher the level of buy-in from society you might need. So, for instance, at the highest levels, it may be that Wes Streeting or whoever currently is the minister in charge of the NHS might have to sign it off to say, as a society, we want to undertake this activity and we're prepared to take the consequences of that. And that allows us to make sure that what we put into place, we've got an agreement that it's appropriate to do so. And on the right-hand side, I just give you an example of what that might look like for that mammogram piece of assessment by machine learned AI that I talked about earlier. So, moving on, I want to try and say, well, we've got this technology. We've had an approach to doing that technology called system safety. We've spent time and effort recognizing what the potential harms that could happen as a result of introducing AI and the challenges for that. And we started to understand how we can mitigate those risks down to a level we're prepared to take on, so that we can get the gain from introducing that AI. And I just wanted to finish with how system safety might help us with that. So we can make sure that we don't just put any old AI that comes along in. We want to responsibly innovate. We want to make sure that it is good, and we've thought about not just the benefits, but the downsides of it, and we mitigate that appropriately with the new technology that we're putting into place. Because if we don't get that right, we'll end up harming people, but also, of course, we'll reduce the trust of people in that AI, in healthcare, and they won't want to get us to put it in, even though it could give us some gains. So what the industries would really like, what the practitioners would really like, is good best practice, good guidance on what they should be doing. And I think here system safety can help us. These 6 elements that I talked about earlier can actually help us build good practice guides, put regulation in place that has appropriate benefits and safeguards in place. And that process is now started, is ongoing. Here's from the 2024, the impact of AI and the regulation of medical products. So if you're going to put it into one of these medical devices, how you're going to show that you've dealt with and understood the safety consequences of it, and that you're pretty sure it's good to put into place. That has moved on. As of September 25, there's now a national commission on the regulation of AI in the healthcare sector. So they're hoping to do all this in a year. So Liz Kendall, who's the Secretary of State for Science and Tech, which is an interesting person to be leading it, I guess. And her comment was, this commission will ensure the UK leads the way in making these game-changing technologies available in the safest possible way, helping more of us to lead healthy, longer lives and supporting our NHS. So there she's talked about the benefits, but she's also saying that we really want to make sure that we haven't got the downsides for safety. And the organisations, the university and various other medical organisations that we're involved in, we're hoping to put information and work into there. So watch this space. Hopefully we'll be able to accelerate AI safely, losing all those system safety principles we've been talking about, extending what we already do into that space. So where does the team at the University of York come into this? Well, the University of York has been looking at high integrity systems, looking at system safety engineering since the early 1990s when software first came in. That's why a computer science department is the leading authority on system safety in the UK, because we were looking at how to deal with the introduction of software. We've now extended that into looking at AI, and we when it's in used for robotics, but also for information systems. And we've produced a number of pieces of guidance that at the moment are gaining influence for regulation and for best practice. So the first one is something called praise, and that's looking at the ethics argument, asking the question, is using AI here something we should be doing? Or are we actually undermining people's autonomy, or putting people at risk that we shouldn't be putting at risk, or in a way we shouldn't be putting people at risk? And we're talking about how to build a case for that and get that agreed. So once we've agreed it's a good thing to do, we can go and build it, but we want to produce a safety case for why using that technology in that healthcare setting, that pathway is good, and why we've dealt with the safety appropriately. We've then got guidance on how to, for machine learned specific AI, how we can actually show the contribution of the AI to the safety of healthcare. And we're currently working on how to incorporate things like chatbots, things like ChatGPT into systems, and that should be coming out soon. So our flagship for that is to have a guidance on how to go through a set of activities and produce a safety case for that contribution of AI to safety. It's called AMLAS. I've just given you the diagram here, the set of things you have to do. The medical people, NHS England, have actually taken that process and turned it into a standard, BS 30440, for those of interest, from 2023, that shows you how to go through that process and build a case that it's safe to put a piece of AI into your healthcare, and for clinical safety and clinical risk officers to accept that in a healthcare setting. But I just want to finish here on another part of this issue. We need, at the moment, and quite rightly, healthcare is human-centric. It's all about caring for people. It's not a technology is an aid, an improvement, a helping, a facilitating capability. We need to make sure that, that good old joke of the computer says doesn't become dominant, that we still can keep that patient-centric, that human-centric approach to the world. And there's people that I'm working with at the moment who are trying very hard to make sure that we put that in that role, that the tasks we ask the machine to do and how it interacts with the people, make sure the clinicians make sure that we have good human-centric care. But there's another group of people that potentially can be at risk here, and that's the clinicians. If we're not careful, clinicians will be held responsible and accountable for things that they don't have any control over. So let me ask a question. Suppose some patient safety incident occurs, so there's some harm caused to a patient during their cancer care, like the THERAC. At that point, you have to ask yourself, who's going to be held responsible for that harm? Who's going to be held accountable? So who's going to be responsible for the consequences? Who's going to be liable to pay damage? If you're a clinical practitioner, can you get your insurance to cover you against the potential for a payout because a piece of AI that's part of your pathway has caused harm? What is it realistic to expect of a clinician who's in that team with a piece of AI to be responsible for in terms of making sure that AI works or not, and any harm that gets caused by it? And historically, we've given most of that responsibility and accountability to the clinician, because they are the people that have decision autonomy. They have control of the situation. They determine what should happen and when it should happen and how it should happen. We can hold them responsible. There's a little bit to the patient. But AI is taking that capability away from them. It's removing their authority. It's removing their control over the situation. What does it mean about what that responsibility allocation should look like? Are we going to have to make developers of AI responsible and accountable for any harm caused by the AI? What's the mix going to be? And I've just given one possible example here. And actually, that's a pretty awful example. Because if you look at the first clinician bit of that diagram, it says clinicians are going to be mostly responsible and accountable, but they have no authority and control. That can't be right. So at the moment, there's work going on to try and work out how to do that balancing act. If you want to hear more, you want to learn more, the Centre for Assuring Autonomy at the University of York has been around in one disguise or another for the last 8 years. It's had 2 rounds of money from Lloyd's Register. The first round was 10 million. We got another 43 million pounds worth of activity out of that investment, and Lloyd's Register have come back and given us some more money. This is all building on existing capability. So we have the UK's premier master's programme for industrial people on safety in safety critical systems. We've in 1996, for our early work in the software, we actually got a Queen's Award, and this is my boss, John McDermott, getting his OBE from the late Queen from that. And we're continuing on with that at the moment. We now have the only centre for doctoral training in the UK looking at these things. We have, at the height, we'll have 65 PhD students currently. We may have a few more. Looking at how to deal with these issues, not just in healthcare, but elsewhere, but also quite a lot of it will be in healthcare. And as you can see, the 2 main challenges they're looking at is what is the safety of AI-enabled mobile autonomous systems in open contexts, so things like cars, but also in medical, and how we look at the safety of the human AI team. What's my final take-home message here? Healthcare systems are changing. We have no choice. We need to have better throughput, quicker throughput. We need to improve the care of people as we have an aging population. We've got issues to make sure we cope with. We've got decision making by machine rather than by human, rather than by clinician. We're going to have to figure out how AI can replace software. The nature of the challenges are changing as we introduce this new tech, but we can build on what we already have. We can try to understand, as hopefully I've shown today, how to improve our understanding of safety. We do what we've been doing for the last 30 years in terms of system safety. The basics of that we need to do well. We don't want to throw it away. We want to improve our practices. We want to improve our ability to do ethical and risk acceptance. And we want to make sure that we can keep looking at the safety of a system throughout its life and make sure it might have been safe on day 1, but by year 4, it might not be safe. And we want to make sure we can manage that. And if we do all that, it will be good to introduce this AI to get these improvements on all these sorts of elements that you can see at the bottom banner here. And probably these days there's another hundreds more possible gains we can make. So, thank you very much for your attention. Questions? And I'll have my cup of tea while you're thinking about it.
Thank you very much, Mark. Yes, thank you for that. And yes, amongst all those points and questions, there were probably a few questions that we always thought are coming in our healthcare practice and treatment in the future.
I mean, you know, what I really don't want people to take away from this is that we shouldn't be doing this. There is a lot of gain here, but we have to make sure we put in the right checks and balances so that when it's something that isn't going to help us, we can reject it. And one of the problems I'm seeing is that people have got nice, shiny, it's nice and shiny tech in their eyes. And if we're not careful, we'll have a few poor examples that will then muddy the water. And that's what we're trying to guard against at the moment. Yeah.
We have a question or a comment from I think it's from Steve Sadler, who says, "Thanks, Mark. Very interesting. I've some experience of safety critical systems design where principles such as redundancy and diversity have been critical to avoiding single points of failure."
Absolutely. Yep.
Yeah. Can you foresee diverse AI systems being used to cross-check each other's homework?
Absolutely. Yes, we can. And we're talking quite a lot about those different architectures now, about how we can use all those classical control, monitor, diversity, redundancy type stuff. But if you're going to say redundancy between two pieces of AI, what does diversity mean? What sort of differences in data? What sort of differences in the way it goes about its learning? We're currently looking at whether that's plausible. In the first instance, it's much more likely that we'll have a non-piece of AI checking the AI's homework and will be quite conservative. So if the AI is doing something that actually is okay but not obvious, we might reject it anyway in the first instance until we can go and look it up and check it out. But yes, eventually you'll end up with diversity. And there's a lot of work about monitoring that capability and that cross-checking and what that might look like in the future.
Yeah, because if the diversity is only a superficial one and they're actually using the same data, then you're actually just reading two copies of the same newspaper
Absolutely
to see if what one says is true.
Yeah. And of course, all that two copies will give you is if they come up with a different answer, it will make you say, well, I don't know whether which one is correct. So you still need a fallback to say, at that point, what do we do? Because we don't know which is right at the moment. What do we do about that? We need to have that in place so that we don't just rely that fallback process has places to go and improvements to make. And I absolutely agree. We will end up with eventually figuring out how one bit of the tech can check another bit. At the moment, we'll try to be very diverse and we'll probably end up with most monitors being human coded software checkers rather than another piece of AI.
Right. Okay. Do feel free to put anything in the chat box for those who are attending if you want to raise a question. Let me just ask something. You talked about the human on the loop.
Yes.
One aspect that's always concerned me in healthcare in particular is that some jobs where those practitioners who have the skills now can check whether the AI is getting things right.
Absolutely.
But in a generation time
is not a generation.
Not even a generation, but you may end up with de-skilled.
Absolutely.
Because we know that a practical skill like this just needs constant trying and practice and attention, and you learn things in a couple of months' time that you didn't know before. Whereas if all you're doing is checking what the AI comes up with, you're losing those practical skills.
Yeah,
so your checking is less effective.
Yes, absolutely. So at the moment, we've got one of our safeguards is to defer back to a human being. The human being might be the cross-checker. They're the person who's got the on-the-loop oversight and will go, oh, that's not right. While we have these experts, that you are correct. There's lots of evidence about how fast you lose that capability. And in fact, one study by MIT very recently, what they did was they put ECGs and things onto people's brains. And then for a month, they got these three groups of people to do essay tasks. One where the human being had to think their way through it, go look in books, do that sort of stuff. One where they were allowed to use Google search stuff, and one where they used ChatGPT. After 1 month, the people who were using ChatGPT had almost stopped doing critical thinking. They were into cut and paste. And you could see why their brains were firing differently. And they monitored them afterwards, and the re-ability to do critical thinking, to understand and to undertake the tasks took a long time to come back, even after only 1 month for that. So you're absolutely right. One of my big worries at the moment as an educator in this area is we're going to get skill fade. But also, of course, how the heck are we going to get the next generation of experts when they've never had to do the day-to-day stuff? The easy-to-do stuff they'll not see. So how the heck are we supposed to get them from nothing to experts in 5 minutes? It's just not credible. So somehow we've got to build training and education programs and experience programs that stop that shortcutting thinking fast stuff enough to keep experts into the future. Otherwise, we're just throwing away any chance of a human checker.
Yes, that's right. You just simply have someone accompanying a machine.
Yeah. They're just looking at it to be nice and be there to get blamed. And that doesn't seem like a very good idea to me for all sorts of good reasons.
Do you see that being built in to the use of AI in healthcare?
What, the
need to continue?
Oh yeah, people are we're starting to, but it's lagging. So you can see what the gain is in the short term. So people are wanting to get that, and I absolutely agree. They can see that, for instance, nowadays you can get a scan quite quick, but you won't get the results of that scan for 6 weeks. Why? We physically don't have enough people to look at those scans and understand them. So we've got to get throughput. But if we're really not careful, we'll end up without that capability. The institute I work for is trying to push very hard that we need to build that professional capability profile in, and need to understand how to go through that into the future. And like today's education review for what school kids are going to go, it's not going to be a one shot. We're just going to go around in circles a lot until we figure out how to do that. I don't even know what a chartered clinician will look like in the future.
Oh, that's yes, that's a newish role.
Yeah, and I think there will be quite a few brand new roles around. If you go back to the Therac, one of the problems was the operator just did not understand what the calibration, as they called it, the machine was doing. So they made an adjustment, and then the machine made the same adjustment on top of it, which meant, of course, because they just didn't understand what was going on with that machine. And that's where all the explainability stuff starts coming in. It's really tricky to figure out how we're going to balance that activity and make sure that that's why I put right at the end, we've got to be careful not to make a clinician a liability sink, because they'll walk away. And we won't have a capability, and we need the checks and balances in that human AI team.
And is this National Commission that's looking at healthcare safety? Are they?
I don't know. I haven't got the details of their tours at the moment, and we're trying to get hold of those so we can see if that's in there. And if it isn't, we're going to be pushing very hard as part of the consultation processes to say you have to think about that. If you think about it, the NHS has got the biggest workforce in the country. It is completely human-centric in the way it does things at the moment with a bit of tech to help. They're literally trying to flip that on its head. Now, that isn't going to work unless you think your way through what that education and training and workforce capability looks like.
Yeah, fine. So there's a battle to take place there.
Yes, absolutely.
Because patients aren't just a heap of symptoms and
no.
And bits and pieces that go wrong.
Yeah. So, there are a lot of people, the old-fashioned human factors and ergonomics people who are really trying to get to understand how that in the new age will work, how to make sure it remains human-centric, how the task analyses for the human bit of the team can work such that we keep that human-centric nature of it. And that's why I said it isn't just safety, it's ethical as well. Just because you could do it and it would be safe enough, is it ethical to do it that way? And that's a societal question, not an engineer question, which is why we need to get people to engage with it.
Right. In the absence of other questions, let me just ask one more, which is that while anything to do connected with the government and health and the NHS is clearly being looked at really carefully in terms of system safety, what about a lot of private activities that go on that are related to healthcare? You've got cosmetics and lasers and skin care, and you only have to go on the high street and there are various people who do things. Would they be bound by system safety?
And this is I think this is one of the areas that we need to. This will extend what regulation needs to look at in ways that we haven't had before, because the capability of these people will alter, and their ability to do good things but also harm will alter. This is happening all over the place. If you think about civil aerospace and automobiles, they're very separate domains doing their own thing. We're now talking about air taxis. So how do you regulate in that space when they're both a car and a plane?
Yes, yes.
Anyway, I noticed that people are saying there's
there are some chats. I've now seen some. One here. When AI develops further and it becomes cleverer than humans in writing software and designing systems, will we even understand what AI is doing, and how and where to place the necessary checks and balances?
And the answer is, of course, we have the potential for that to be the case. And so we have to think about those architectures and those constraints, and how we can improve our ability to understand that and put it in the appropriate box. There's a lot of work that's going on around this thing called explainability. From a system safety point of view, I'm not sure that is going to give us as much as we're hoping for at the moment. We're also back to your statement about the private providers. The EU AI Act asks them to provide information so that the regulators and people and the public can understand the safety of their products. Right. Commercial says they're not going to. The capability of the machine is going to be so high that we don't understand it. And that's why these safeguards and putting stuff around it, the wrapper thing, is going to become so important. That, yes, you can do this weird thing that's, Arthur C. Clarke magic, but because it's such a level of science, but we need to wrap it in such a way that then can't do things that we don't understand, even if we don't know the mechanism for it to understand that. And you're absolutely right. That's going to be a constraint on what we should be doing
Mm.
for quite a period of time, I think. Otherwise, we are getting AI to check its own homework, and we have no way of checking that works for us.
Yes.
And,
And
and that's a risk. It's not an existential risk, but it's a risk.
yeah, obviously the essence here is regulation, and I'm not sure all these private things in the high street are regulated. But the other question is then, what about developing countries? What about healthcare in
Yes.
developing countries?
Yes.
Will that be as regulated?
Almost certainly not. Um, One of the things that the exponents of these things say is we will improve healthcare in these places because they don't have the clinicians and they don't have the capability to generate them because they can't afford to.
Yes.
So technology is a shortcut for them because they can download the app, and the app's been created by people who do know these sorts of things. My worry, of course, is, and we're already seeing it here for acceptance into the healthcare, is if your AI model is learnt on white middle class affluent
Yes.
people,
Yes.
and the people it's now supposed to be providing information and diagnosis and medication doses for are not white, middle class, affluent people. How's that going to go?
Yeah. One last point, the question of mental health support. And in the pandemic, many new apps were launched for anxiety and stress and much machine learning. But much of this machine learning will have taken place there. But the
Yeah.
data owned by somebody,
Yes, absolutely. And of course,
how shared?
so yeah, this is a big issue. So if you end up looking at that last guidance, part three says make sure the data is good data. Look at where that data is coming from. Make sure you understand who owns it. If you can't, you've got to have access to it. At least somebody's got to have access to it to review it. It's good, it's accurate, it's balanced, all those. It's correct. And there's a huge minefield about who owns all that. Places like the NHS, of course, are sitting on a gold mine because they've got data. They've
Yes.
whether it's particularly good data is another question. But you're absolutely right. One of the ethical questions here is around the privacy of that. So if you've talked to a chatbot, it probably got recorded. So it could be fed back to the AI to learn better how to interact with people. But B, so that checkers could check that the AI was saying good things. Next question, where is that sitting? Have we got proper safeguards over who can see that, when they can see that, and all that? Now, the good news is the NHS has been trying to play that game for 20, 30 years now, and is actually way ahead in ensuring that's good. In comparison to Alexas of this world type people.
Yes.
You know, they do collect all that data, they do improve, so they logically could find out what was happening in your home at a particular time. They don't because they've no interest in it, um, because they're only using it to improve their AI. But, you know, that you're absolutely right. All that data and who's got data and the interactions and who can see that and how you can make sure that's confidential and private and all that, and at the same time becomes available as appropriate to be used to improve care in the future. That is one of those huge minefields at the moment that all the domains are looking at. I would say for once, healthcare's probably a bit ahead because of the way their ethics and data committees work. They'll have to try and figure out how to keep up to date with it, and that's going to be a bit of a challenge.
Well, Thank you very much, Mark. I think Mark, we've kept you quite longer than normal, but I think that shows uh, the importance of the topic, and we'll look forward to seeing how it develops.
Brilliant, thank you. So yeah, as I say, if anybody's interested, they can go and look on the CFAA websites and stuff.